So next topic is OCT. Is it mandatory in neuroophthalmology? Myself, Dr. Rehna, will be presenting it. OCT, is it mandatory in neuroophthalmology? So in neuroophthalmology, OCT can be used objectively to assess the structure of the optic nerve head and peripapillary retinal nerve fiber layer. The peripapillary retinal nerve fiber layer is actually the axons of the ganglion cells. It has the advantage of giving this reproducible and quantifiable measurements. The thinning of the peripapillary RNFL is an objective marker of optic atrophy, but to give a complete picture, they have to be performed in conjunction with subjective assessment of optic nerve functions like visual acuity, color vision, and visual field examination. First, let's have a look at the way the fibers are represented on the retina and optic nerve. So if we take the fovea as a center of fixation, the fibers from the temporal aspect of the fovea is the temporal fibers, and the nasal aspect is the nasal fibers. So these blue fibers, the nasal fibers, are crossing at the chiasm. So papillomacular bundle represented in the temporal aspect of the disc, and these fibers at the nasal, and the temporal fibers at the superior and inferior aspect of the optic disc. So quantitative measurement is the one which we usually do in assessment of neuroophthalmological cases. So we look at the thickness of the peripapillary retinal nerve fiber layer, which with the average reading you can get it from here and the sectoral readings from here. Similarly, we also get the thickness of the ganglion cells. So let's go to few cases. This is a 23-year-old lady presenting with headache with a visual acuity of 6.6 in both eye. The disc showing bilateral disc edema. So what is the most probable diagnosis? Papilledema. So obviously in the RNFL we would be finding out this marked thickening of the retinal nerve fiber layer, which is shown as white in color, and that confirms it. And to investigate, the patient was investigated with MRI and the CSF pressure was found to be high. The diagnosis is idiopathic intracranial hypertension. So here the use of RNFL, OCT RNFL is not for the diagnosis, but when you are treating the patient, the sequential scans make it possible to monitor the patient, to know the response and when to stop the treatment. And it's also effective in such cases where we're not very sure whether the optic disc is thickened or not. It would confirm the thickening. And there is a study which is based on OCT, which is idiopathic intracranial hypertension treatment trial, which showed a greater reduction in the mean RNFL thickness among the Diamox patient compared to placebo. So regarding our first patient, the patient was started on Diamox, and slowly the thickness reduced, came back to normal. Now we'll go to the second case. This is a 6-year-old girl who came for routine examination and gave a history of occasional headache. Her visual acuity is 6.6 in both eye with hypermetropic correction. So if you look at this, there is slight margin blurring superiorly and slightly hyperemic. So you will be in a situation whether it is an early papilledema or is it a pseudopapilledema. But to diagnosing that is very important, because in case of pseudopapilledema, if you are diagnosing pseudopapilledema in a case, that would avoid unnecessary investigations like MRI and lumbar puncture. But diagnosing a papilledema, which is there, is also very important because it would be associated with serious neurological disorders. So if the OCT RNFL comes out like that, that's ruling out papilledema, most probably pseudopapilledema. But most of the cases we have found that it comes up something like this. There is some thickening of the peripapillary RNFL layer, where again we are confused whether it is an early papilledema or a pseudopapilledema. In such cases, we can go for B scan or FFA without leakage would confirm that there is pseudopapilledema. Also in OCT, there is another way by which we are looking at this RP basement membrane hyperreflective layer. This is a scan which is done, HD OCT, which is done through the optic disc. So if this hyperreflective layer, in normal patients, in normal individual, it's turned away from the vitreous, which is negative. But in case of papilledema, because of the biomechanical forces which are acting on the load-bearing structures, it can turn into the vitreous. So that can be also used as an ancillary test in diagnosis. And in case of pseudopapilledema, you would also be able to see these hyporeflective lesions surrounded by hyperreflective margins, which are actually drusen's in pseudopapilledema. And again, you can note here, this is turned outside, away from the vitreous. So we did a study on this angle between papilledema, pseudopapilledema, and normals, and we found that around 70% of the patients with papilledema had an angulation which is turned towards the vitreous, and the rest were neutral, that is flat, and we didn't find any negative values. But in pseudopapilledema and normals, either neutral or negative values were there. Now let's look at the next case. Young girl with a decreased vision in the right eye, pain on eye movements, visual acuity is 624 in the right eye and 66 in the left eye, with RAPD in the right eye and defective color vision. What is the diagnosis? It's optic neuritis. So here, the disc, the field was showing centrocecal scotoma, and this is something we do expect because the disc was edematous. So that would help to quantify the amount of thickening. So that is helpful, but it's not required to repeat the OCT RNFL every visit, because that's not going to help in the management. But in MS patients, as it was discussed before in the ERG VEP, OCT can detect subclinical axonal loss, even in those patients who never had an optic neuritis, and so we can know that the patient had subclinical optic neuropathy before. And also it's been found in studies that macular edema and thickening of the inner nuclear layer on OCT were associated with disease activity and worse disability in multiple sclerosis. And also the ganglion cell loss is a predictor of short-term visual field improvement, like color vision or contrast, which usually happens later in course of the disease. The other use of OCT in neuroophthalmology is as a prognosticator for cellular and paracellular tumors. So in cellular and paracellular tumors, the visual field defects and the visual field improvement, to an extent, a lot is dependent upon how much damage it's caused anatomically to the structures of the eye. So let's look at a case. This is a patient with a cellular tumor, and you can see the visual field defect. There is temporal heminopia, superior temporal heminopia here. And if you look at the OCT, RNFL and ganglion cells, there is not much change there. And the patient underwent surgery. And 1 week after the surgery, the visual field has completely returned to normal. On the other hand, if you look at this picture, there is a marked thinning of the RNFL and GCC here. If you look at this type of loss, it's a binasal kind of ganglion cell loss, which occurs very typically in cellular tumors. That's because these are the nasal fibers which are actually crossing at the chiasm. So this was a visual field defect, bitemporal hemianopia. And after surgery, this is 6 months post-surgery, the visual field didn't improve completely. It did improve, but it didn't improve completely. Another use is in ethambutol toxicity, like drug toxicity. Nowadays, we are seeing more of the ethambutol toxicity patients. As we know, the dose of the ethambutol has been increased, and the ethambutol has been stretched onto the continuation phase. So there are a lot of studies which are being done to know whether we can detect subclinical optic neuropathy in patients so that the drug can be stopped. And these studies have shown that there is initially there is some thickening of the peripapillary RNFL, and later on thinning, which occurs later after 6 months or 8 months, especially in patients who are higher dose and a longer duration. Okay, but there is no consensus regarding whether to stop the treatment just based on that. We have to go with the findings with visual acuity, color vision, contrast, and fields. Now, another area where studies are going on is in Alzheimer's and Parkinson's, where they have found thinning of the RNFL in both the conditions, and it's more marked in upper and lower quadrant, not in the nasal and temporal quadrant. So such findings indicate that the loss of the retinal ganglion cells may reflect more widespread degenerative changes in the brain. So to summarize, the uses of OCT in neuroophthalmology, one is papilledema and IIH to diagnose and to monitor the treatment, pseudopapilledema to differentiate from papilledema, and in optic neuritis and AION to quantify the thickening and also to prognosticate the visual recovery, and drug toxicity, and as a prognostic predictor for cellular and paracellular tumors pre-surgery. Thank you.
Thank you, Dr. Rehna. It was a very informative presentation on the use of OCT in optic nerve disorders.